I'm going to really start on time, so people will log on as obviously their time is available. And I apologize for the hum in the back. I know that at Rutgers we're getting hit with inclement weather. The temperature is direct opposite here, so I've got to keep the AC on, so that constant hum, I hope, is not too distracting. Otherwise, let's kick it off. We were discussing the pathology demonstrated through our assigned film, The Lighthouse. So if any of students or clerks have any initial thoughts, where they would like to start, what character, what observed behavior you'd like to kick things off for our discussion.
So I thought it was pretty clear that, there were elements of psychosis with the two gentlemen on the Lighthouse. And since it was just the two of them, I know there's the concept of folie à deux, the shared psychosis. So, I think that would be one thing to start off talking about.
Yeah, so to frame this, if we are looking at this behavior and we do think there is a breach from reality testing, and therefore the clinical term we'll use to describe the behavior is psychosis, that's going to put us directly and immediately into the chapter of the DSM titled Schizophrenia and Other Psychotic Disorders. So with that in mind, I do want to get to this concept of folie à deux, or what was previously known as shared psychotic disorder. Anybody have a feeling of which character is the primary focus? And I know this is completely arbitrary, but I want to kind of get a quick consensus in terms of just the first step to this process of case formulation.
I think if you're going to say the Robert Pattinson's character, Ephraim, yeah, okay. I think he's the primary character, if there is two characters.
I was going to go there too as well. All right, so if we're going to agree that there are in fact two characters in this film, Ephraim or Ephraim, yeah, I think is perfectly plausible in terms of where to start. Does he rule in for schizophrenia? So I know this is a stepwise discussion, but in case formulating The Lighthouse now as a fictional presentation of schizophrenia, what are the five symptoms that we want to evaluate for? And knowing that the DSM requires two of the five, does this character rule in?
Hear me okay? So he had what I presume would be hallucinations. So that's a positive symptom. He, I think, thinking back, probably had some delusions as well. His behavior was disorganized. At times his speech was disorganized. And then, so that meets the criteria, but negative symptoms would be like anhedonia, alogia. There's many more. But is that fine?
Outstanding. If we are not in full agreement that Ephraim demonstrates negative symptoms, and for those who have a shelf in their foreseeable future, negative symptoms largely result from too low a dopamine level at the level of the mesocortical tract, just in case you're asked. Even if we don't have full consensus that they are on display here, we have our main character demonstrating all four positive symptoms, those signs that are the pathological presence of something that at baseline should not be there as a result of a hyper dopamine state at the level of the mesolimbic tract. So in this part of our conversation, at this point of our diagnostic algorithm, yes, the character we have selected is in fact ruling in for schizophrenia. I'm also focused on his age, which is certainly, as per the medical literature, consistent with new onset psychosis, 18 to 25, 18 to 30 years of age, the largest majority of new cases. So moving forward, at this point, we have to appreciate that this condition is, in fact, the diagnosis of exclusion. What 5 conditions must we now investigate to further evaluate for schizophrenia in our main character?
Do we need to evaluate for the absence of an underlying medical illness? Is that what you're going with that as well, or substance induced?
3 more. One would be a primary mood disorder. Number 4 would be a psychotic condition called schizoaffective disorder. And the 5th and final diagnosis, as per the DSM, as per the American Psychiatric Association, is an autism spectrum disorder. Okay? So let's start off with autism spectrum. The Lighthouse does depict a history, pre-existing condition, of autism spectrum. A, yes, B, no, C, doesn't matter. So in the context of evaluating for schizophrenia, A, yes, B, no, C, doesn't even matter.
I didn't believe it mattered.
We're getting an echo.
Okay. I don't think it necessarily matters in the context of what we're concerned for here.
Exactly right. And the reason why is because the APA requires this investigation for individuals with this pre-existing condition, largely due to the overlap in clinical features, specifically disorganized speech, grossly disorganized behavior. And while it is true that our main character demonstrates both, he also demonstrates 2 other positive signs that do not overlap with an ASD, delusions and hallucinations. So for this particular presentation, it doesn't matter if there is a prequel to The Lighthouse demonstrating Ephraim as depicting an autism spectrum disorder, because his new onset hallucinations, his new onset delusions still allow us to evaluate for schizophrenia. Focusing on the organic pathologies, organic here defined as either an underlying medical condition or the direct and physiologic effects of a substance. Any concern here as to defining his psychotic symptoms?
Yeah, because yes and no, because yes, he's consuming substances, but I wouldn't say that there's necessarily a strictly concordant history of consuming one substance, in part because there's no supply chain there, and there's no evidence that he smuggled in enough of one particular substance to last the whole time. So I wouldn't, even if it was the effect of multiple substances, I would expect probably different effects.
Okay. Other than alcohol, is there any overt evidence of any other substance that can induce psychosis?
I don't know if there's evidence necessarily for this, but the William Dafoe's character cooked all the meals, so there is the potential that he could have been doing something, slipping something in to the cooking, and there was a couple occasions where he was insisting that he drank whatever alcohol they were drinking. So there's that's another angle. I don't know exactly what substance, but something that he's putting in the food or drink.
So you're a little suspicious.
Yes.
Yeah. Interesting that this movie results in that kind of transference, because that almost connects you to the character himself. But that's another layer. We won't get into that. We could save that for another day. Any other substances that you'd be concerned about before we tackle alcohol?
What? Other hard metals, it's from seems like a historical era where maybe we weren't as careful about that, and there could be long-term toxicity, especially depending on what they're doing, how they're burning things, or it's something like carbon monoxide if they're inside a long amount of time and they're heating with fire.
Yeah, so it's not to put words in anyone's mouth, but it does seem like there's enough concern here where you would provide a full workup for any organic pathology, including heavy metal assay and similar type of testing. And did I hear correct? And there was an echo, so I may have been off base. Did I hear turpentine before? Okay. I mean, that might be a little different than alcohol here. So if we're going to put alcohol at the top of our list, and perhaps we should, turpentine deserves a little bit of a tangent. Turpentine, especially the vapors, the fumes, would be more consistent with inhalant intoxication. Now, the good news is that there is no such thing, as per the APA, of inhalant withdrawal. So there's no physiologic withdrawal state of inhalants. So the primary concern would really focus on intoxication. There are 4 subclasses of inhalants. Now, hopefully I'm going to get these correct. That they would include solvents, aerosols, gases, and nitrites. And turpentine's likely a solvent, right? So I think we need to keep this in our differential because inhalant-induced psychotic disorder, I think, would be a viable condition to investigate in the Lighthouse. Again, so we're talking about solvent exposure, specifically the vapors of that solvent, and in this case, maybe specifically turpentine. In addition to this, I heard significant clinical concern of the direct physiologic effect of alcohol. Now, what's interesting here is that these signs and symptoms of intoxication are with significant overlap. That is, alcohol versus inhalants. So on a shelf exam, on any standardized exam, inhalant intoxication is going to look like someone is drunk. There are 2 things, though, in the clinical vignette that will allow you to choose, for example, choice A, inhalant intoxication, instead of choice B, C, or D, alcohol intoxication. Number 1 is euphoria. Okay, number 1 is euphoria. Alcohol is a CNS depressant, and while there is significant disinhibition at increased BAL at elevated alcohol levels, it is not going to induce a euphoric state. Inhalants, on the other hand, can. So that's one of the differentiating characteristics of their relative intoxication syndromes. Number 2, neurological sequelae. The neurological sequelae of alcohol use disorder occur decades later. That is, after decades of use through the depletion of vitamin B1 or thiamine. That is not the case for inhalants. Inhalants may induce neurological effects immediately during the acute intoxication state. So that helps differentiate as well. So in our differential, we're thinking psychosis, we're thinking schizophrenia. However, we may not be comfortable definitively ruling out a substance-induced psychotic disorder, while alcohol and/or could be co-occurring. Inhalant use might be or might have a role. At this point, I want to briefly pause. We're about a quarter way through our discussion. Any questions or comments about where we are right now in our diagnostic workup? All right.
Yeah, I guess I do have a question. I wasn't sure how clear it was in the movie, but I know, like, with the DSM criteria for schizophrenia being like over 6 months, like how that factors in, given that we don't know exactly how long they were on the island. Like, they kind of alluded to it, but we don't really know anything before or the exact timeline.
Great point. So if we're sitting in front of our patient right now, one of the things in terms of duration of symptoms would be to differentiate between brief psychotic disorder versus schizophreniform disorder versus schizophrenia. Right? Brief psychosis or brief psychotic disorder, 1 day to 1 month. Schizophreniform disorder, 1 month to 6 months. Schizophrenia, 6 months or greater. Right, so the timeline definitely has to be delineated, and we just don't know the prequel. We don't know of how long this has been going on, but it certainly would be something that we'd inquire about. And the investigation largely is to differentiate brief psychotic disorder from the rest, and the reason why is because of prognosis. Brief psychotic disorder, by definition, alleviates in no longer than 30 days. At day 32, what we may have thought could have been brief psychotic disorder now has to be reframed. So one of the questions that you're going to get, and perhaps I'm just reframing your question, is that if this individual did present with 2 weeks of the signs and symptoms that we're observing, and we could review and we could actually confirm that, just for the sake of discussion. One of the questions you're going to be asked by this character, one of the things you will be asked by his family is, Doc, how long is this going to continue? Will he fully recover? And in the back of your mind, and this is the way you should approach the test question as well, if this is in fact brief psychotic disorder, the answer is yes, that there's going to be a return to premorbid functioning. Now, as a clinician, you do have to delineate, so this is more of a clinical parole, between this condition called brief psychotic disorder and schizophreniform disorder that you've caught very early. Family history is going to be important here. Unfortunately, as we've watched this movie, if we read the script, we're really not provided much of a family history. This character's biological parents, monozygotic twin, other sibs, etc. So that history is missing. So that's of no help. Let's get back to what we originally and initially approached, negative symptoms. So I kind of glossed over it before and said even if there's no consensus, that there's evidence of elogia or anhedonia or attention deficit, etc. I think we're going to have to return back here, and I'll tell you why in just a second. Question to the group. Do you think there's evidence of negative symptoms in the main character? Let's look at anhedonia. Could you make the case? Can anyone make the case that this individual does demonstrate anhedonia in as much as investigating his motivation for coming to that island to begin with?
I guess. Okay. Sorry about the echo, guys. I guess you could argue because he didn't really seek to become a lighthouse keeper. He just did it because of the money it would provide for him for a steady living. And that he kind of shifts from one job to another. So he's not really interested in the job itself, just like what he can get out of it, which is the money.
Yeah. And wasn't there also an allusion to his running from something? His running away from something? I think at the very least, this would be a topic of inquiry. I'm just wondering if anhedonia might be playing more of a role in this movie than perhaps we've given it credit. There might be some attention deficit here as well. And the reason why I think this conversation is critical is because if there's evidence of negative features, 2 weeks of psychotic symptoms as portrayed in this film are much more likely to be indicative of schizophreniform and even with progression to schizophrenia than brief psychotic disorder. That is, brief psychotic disorder usually, does not have negative symptoms as part of the definition and is a poor prognostic indicator when seen in the context of psychosis, even within 30 days, right? So unfortunately, if we do believe there are negative symptoms here, this story does seem to be consistent with, at the very least, schizophreniform disorder, if not schizophrenia. Okay.
I have a question. I
think you muted yourself.
Sorry about that. We're all in the same room. So anhedonia is like a inability to experience pleasure. And if we're saying he has it, but if when they're drinking and like having like a great time and stuff like that with a substance being involved, does that kind of like not qualify that or not disqualify anhedonia because they're drinking?
Correct. There's no disqualification if the individual's drinking and is under the influence and is disinhibited. We as clinicians can't point to that and say, see, he's enjoying himself. There's no anhedonia here. No, we wouldn't do that now.
Okay.
No. However, you bring up a good point. I mean, anhedonia is also indicative, consistent with other conditions as well. We need to get to them. The role of alcohol can further be kind of extended here, maybe as a form of self-medication. So let's talk about depression, of which anhedonia is a component, as well as a bipolar or related disorder, of which anhedonia may be consistent. Because we do have to investigate these, that is, a primary mood disorder, in order to further evaluate for schizophrenia. It is in the rule out. Do we think there are depressive features here, or do we think there are mood features here? If the consensus is no, if you're truly comfortable in saying no, we can then remove not only a primary mood disorder with psychotic features, but also remove schizoaffective disorder within, or out of that differential as well. Do we think there's a significant mood component?
So in terms of like the Siggy Caps components, it doesn't really seem like he has a lack of sleep, although it's hard to tell. It seems like he's like been woken up by the William Dafoe character. And then in terms of like interest, I guess that might be a potential like qualifier, like one. The guilt component, I think he might have, because he keeps going back to how on his previous job he might have killed someone or something. I'm not really 100% sure what's going on there, but so he might potentially have like interest in guilt. I wouldn't say decreased energy necessarily, although I guess that argument could be made. And then concentration, I guess that argument could potentially be made, but it's not as clear. Appetite, though, he's although he says he doesn't like his cooking, so I guess it's difficult to completely rule in all the like CAP's criteria, but an argument can be made for some of them.
Yeah. And what you just observed and the opinion you just provided is not inconsistent with a lot of the presentations. That is, in the acute setting, during acute illness, it could be very difficult to get information from a diagnostic interview, similar to extracting that information from a film, which is why it's so important to not only get collateral information, but collateral information about the past psychiatric history as well. We would love to see the sequel, right? The prequel. If the prequel actually was a direct slam dunk depiction of major depressive disorder, we would all agree that a lot of the ambiguity in this film would be clarified. But we just don't have the prequel yet. Similarly, this could be mania. I mentioned euphoria before, and maybe in that context, previous discussion, inhalants in addition to alcohol intoxication. Well, if that's the case, why wouldn't the euphoria be part of a manic episode? But in the same context, the manic episode itself would have to be teased away or teased apart from that which was induced by a substance. So we're still in that role of viewing this behavior in the context of potential substance use or substance use disorder. But I think there's enough evidence here to keep that primary mood disorder in our differential. I don't think we should be that comfortable in dismissing it and definitively ruling it out. All right, with that as really the context of and the basis of our formulation, onset of psychotic features cannot definitively rule out the effects of a substance, and with possible mood component not being able to definitively rule out either major depression or a bipolar related disorder. with that as the beginning of our formulation, is there any other behavior that you've recognized that you don't feel as though we've discussed yet?
Well, thinking about, I guess it was Axis too. I mean, the cruelty to animals, that certainly was a scene that stood out in my mind. And not to be flippant about, consideration of like borderline, antisocial personality disorder. I think is something that has to be considered.
So, what scene are you specifically depicting or referencing?
The scene where he's flogging the bird against the rock.
Mm-hmm. So you're and if that is demonstrative of a blatant disregard for and violation of others' rights, others here, including animals, antisocial personality or antisocial traits would certainly be in our differential. Again, in the context of an acute psychotic or even bipolar illness, we would again have to tease that apart. But again, that comes from both perhaps the prequel as well as the sequel in getting that information, but it should be considered, yeah. Mm-hmm. Any other, since we're, and the reason why I asked you to specifically reference or specify the scene, anybody else have a different take on that scene that might even expand this further? Anybody have a prior career, fishing or maritime or other? It's a reach for me, huh?
I've been fishing before. I've never done anything like that to a fish.
Fair. That's good. You'll make a good doctor then. What I'm bringing up is the tradition, the culturally sanctioned belief that if you harm a seafowl, you might be cursed. So with his doing that, I think it was very symbolic of that sanctioned belief. And if that is the case, again, we always have to pivot to think, why not call this normal behavior? And what happened was weighing on him so much that this might all be part of a stress-induced psychotic event, right? So something to consider. And again, I always want to bring it back to giving our patients unconditional positive regard and starting out, at least in our discussion, about this being a case of normalcy. And is this not culturally sanctioned belief? But again, we always have to get back to who it is we're talking about, because I'm not sure which character is real either. But if there's, since both of them have a similar job, they would both have that belief. So another consideration. Any other observations, this or the other character? I mentioned briefly that we have to consider a mood disorder, so let's kind of maybe go in that direction a little bit more. Somebody tell me how, in their mind, this may shape up as a case of bipolar 1. Any support for this?
Low sleep, agitated, kind of the flights of emotion and energy and thought, and could be like a different type of mania, or maybe not an atypical presentation, or not what we directly think of all the time, and impulsivity.
Yeah. All right, so we have some signs and symptoms here that are consistent with a manic episode. Again, area of further inquiry and investigation. So if we believe that this individual does in fact meet criteria, a number of criteria for a manic episode, and those criteria are met for 7 days or more, we're either talking one of two conditions. That is bipolar 1. Of course, by stating that, I automatically state implicit in that statement is that we are reviewing and ruling out the direct effects of a substance or medical condition. So that's a 3-in-1 illness. There's only one other condition in the entire DSM that this may be other than bipolar 1. That, stated differently, if an individual has a full-blown manic episode, it can only be bipolar 1, with one rare exception. Rare meaning 1% of the US population or less. Which condition is that? And you have to know this for your shelf, because even though in the clinical setting, it really is about a 1 in 100 chance, on your shelf exam, the chance is 50-50, right? It's either one or the other. So you've got to know this. Again, I'm going to state the question one more time. You identify a full-blown manic episode that is not attributable to the direct or physiologic effects of a substance or medical condition. Your answer, 99% of the time in clinical medicine, will be bipolar 1. What's the other condition you have to consider? Schizoaffective disorder, bipolar type. It is the only other mental disorder in which an individual may have a manic episode and not be diagnosed with bipolar 1. If an individual presents with signs and the exact same signs and symptoms, but has those symptoms for less than 1 week, what do you call that syndrome?
I'm sorry, could you repeat that?
Sure. Same exact signs and symptoms as a full-blown manic episode. However, the duration is less than a week. What is the clinical term for that syndrome?
Brief psychotic disorder?
Nope.
Or